Hello, and welcome to Great Basin College's first virtual Lunch with a Leader. My name is Chantel Garcia, and I'm the Student Life and Leadership Development Coordinator here at Great Basin College. Joining me is Ryan Hathaway, who is the Housing Coordinator at GBC. We are so glad that you have taken the time to join us today, and we hope that you learn much and enjoy our first guest, Dr. Ezeanolue. We have a few housekeeping items. Please remember to keep your microphone on mute. Also, Dr. Ezeanolue encourages questions to drive his presentation, so please feel free to type any questions in the chat.
Yes, welcome everybody. Thank you again for joining us. Just to give a brief synopsis of who Dr. Ezeanolue is, when not treating pediatric patients, Dr. Ezeanolue keeps busy as an educator, researcher, and policymaker. Dr. Ezeanolue has also served on numerous committees for organizations as varied as the National Institute of Health, the CDC Advisory Committee on Immunization Practices, the HIV Medicine Association, and the National Minority Clinic Research Association. They're also the author of 70 scholarly articles and the recipient of over 24 awards and honors. Dr. Ezeanolue is certainly one of the busiest pediatricians working today. So for our first question, can you tell us a bit about yourself and how did you begin your career?
So thank you so much for having me. It's an opportunity to have this opportunity where people could actually ask these questions, because that's how I started my career. So in high school, we have counselors that will come in and we ask these questions, trying to decide what we want to be when we grow up. So while in high school, when I decided I wanted to be a doctor, I had two opportunities and two decisions to make. One of them was whether to leave and come back. My family was in the US then, to come to the US to go to college and then go to medical school, or to decide to go to medical school in Nigeria, in one of the premier institutions where you could go to medical school from high school. So I made a decision and went to University of Nigeria from high school for a 6-year medical school. You have some of those in the US here also. So I went in for 6 years, and when I finished my medical school in Nigeria, I came back to the US and went to Howard University to do my residency in pediatrics for 3 years. And after that, I went to UMD&J, what is now Rutgers University, and spent another 3 years doing pediatric infectious diseases and also getting my master's in public health. And then I moved from there to University of Nevada, Reno, where I spent the first 10 years of my career.
I think it's amazing that you knew what you wanted to do even back in high school. I think if someone would have asked me in high school what I wanted to do, I would have said something like fashion designer, like something like that. So it's great that you knew even back then, what you wanted to do. So our next question is, what led you to your current position as a pediatrician at Northeastern Nevada Pediatrics? And what about this area, specifically Northeastern Nevada, enticed you?
So it's interesting that you asked this question, because when I was in medical school, you think you're going to live forever and you think you can actually control your career. So one of the things I did, and among my friends, we used to ask ourselves, where do you see yourself 40 years from now? That was the question everybody was asking in the year we're about to leave medical school. So I, at that time, dreamt of my career in 4 decades. So I said the first decade of my life, the first 10 years, I'm going to spend that 10 years learning as much as I could do. And that's what I did. After medical school, spent 3 years in a pediatric residency, spent another 3 years in fellowship, getting my master's. That was my first decade. I call it a decade of learning. Then the second one, I said it was my decade of rise. And the idea was that I was going to rise to the top of my career. That was my dream then. So I took a position at the University of Nevada, Reno, and I went from assistant professor to associate professor to full professor with tenure. That was my second degree of what I call self-actualization. Then I said I would spend the next 10 years, the next third decade was my idea of giving back. And what I thought I was going to do was to teach and mentor a lot of people for the next 10 years. And then I'll go to the last 10 years of my career where I wanted to do some of the things I wanted to serve in other underserved communities. I wanted to do some global health. So was my idea that I had as a medical student, graduating from medical student. So I followed that pathway, essentially spent the first decade learning as much as I could, spend the third decade. But once I was a full professor and tenured, I wanted to move to the third decade in my thinking. And that was the decade I wanted to go ahead and teach. And I thought that the best place for me at the time was actually in a school of public health. What I liked about School of Public Health was that they have master's students, they have undergraduate public health students, they have PhD students, and also because at the time UNLV was starting a medical school, there was also a medical school. So I moved from University of Nevada, Reno, after being there for 10 years and being a tenured professor, to University of Nevada School of Public Health at UNLV. In 2015. Then that was supposed to be the third decade to give back. But a year into that position, I was asked by the president of Nigeria to come to Nigeria and help with the health system, improving the health system. The health system in Nigeria was the largest, or still is the largest health system in Africa. So I thought it was an honor, and I had gone to the university to let them know that I wanted to go and spend a year and help grow the health system. But unfortunately, there was a difference in ideas at that particular time. So I ended up leaving the University of Nevada, Las Vegas. So at that time, I said, now I still have those part of my 10 year I wanted to do, and I have the other 10 years. Then I decided to match those 2 10 years and wanted to see if I could still continue doing what I love to do, which is do some clinical work, which I love to do. I like to do community service, and I wanted to do that at the same time I like to teach. So what I did was just go back to the nonprofit that I've been working with, Healthy Sunrise Foundation, and decided to take a full-time work with them. And during that period, I decided, well, to satisfy my clinical, I wanted to do a travel doctor. What most of you may know as travel nurses. So I started going to places to work. It took me to South Dakota, it took me to Wisconsin, it took me to Illinois, and it took me to Elko. I didn't know much about Elko. The first time I flew into Elko, one of the things that attracted me to Elko was environment. So the place my medical school was in Nigeria is surrounded by hills. They call it Enugu, which is on top of the hill. And when I got into Elko, it was like sitting in this place surrounded by hills. So I felt like at home just by the environment. So I spent time there. So the more, for about a year, instead of going to other places, I started spending more time in Elko. And something changed in me is that in all the places I go, as if you have done travel nurses, you notice that you have different experiences depending on different hospitals that you go to. So in this particular place, when I got here, I just felt that the nurses that I was working with in the unit wanted me to succeed. In every particular thing I'm doing, I've felt that way. One of them, one day I said, this was my day, I believed it, was the day I came in to do a circumcision. It's funny, but I saw them write out my name and they write out my glove size, and they had my glove size on top of the table. I've never had anybody treat me that well. And even to the extent they knew the size of gloves I was wearing and they had it ready. So I had this feeling that the nurses that I was working with really, really supported me and wanted me to succeed. So then and then I said, I was going to spend more time here. So when the CEO asked me if I was going to stay, I was already bought in by then. I liked the environment. I liked the people that I was working with. And he was able to design a schedule that works for me, where I could work clinically, but also gave me time to still do those things I wanted to do, both locally on the communities that we serve in Las Vegas, where I also work in terms of community service, but also globally, where I do take nursing students, medical students to the Healthy Sunrise Foundation to Nigeria for their global health program, and also bringing exchange students from Nigeria to here. So that's what got me to Elko, and that's what makes me think Elko is home.
I think that's pretty cool. So I am a native of this area, and I love when new people come into our community and they feel like it's been their home for just as long as I feel like it's been my home. So I'm so glad that you enjoy our area. So our next question is pretty broad. What does a typical day or week look like for you?
So that's something. Why I laugh about it is that there is a typical day, and I'll tell you why I laugh about when you say typical day. So when I'm in the hospital, I cover 5 areas in the hospital. I cover the nursery for babies that were born. I cover the pediatric floor for pediatric patients that are admitted into the hospital. I also cover the clinic. I cover the labor and deliveries, so I go to deliveries when I'm needed to go to those deliveries. And I'm also available for the emergency room when they have a pediatric patient. So I have these 5 areas that I cover when I'm in the hospital. What makes it predictable or unpredictably predictable is the newborn. Babies don't need your permission to come to life. So my day might start at 8. I'm planning to go to, in the morning, my planned day will be to go to the hospital, sort the babies that were born, make sure they're doing okay, do around on them, and then go to the clinic. But then I might wake up that morning and I get a call from labor and delivery that there's a new baby that is delivered, that is about to deliver, or there's a C-section. So there goes my schedule. Then I go to the hospital, go to these deliveries, and as you will know, some of these babies will come out and everything is fine. So there is no problem. In 5 minutes, I'll continue with my schedule. Some of the time the baby comes out and for the next 1 hour, you are struggling to keep this baby alive. And sometimes, as you know, you may not be able to do that in ELCO. And then you are planning for a transfer to either the primary children hospital in Utah or to Reno. So what was supposed to be a short delivery and in 5 minutes and you go to clinic may end up for the next 3 hours. So in a general day, I will come in, do a rounds, go to clinic, and after clinic, I go back to the hospital and do a rounds. And in between those time, I will go to C-section. But once the baby come, my schedule becomes the baby's schedule, or the baby's schedules become my schedule. So, but that's how my day goes.
So your schedule is predicted by tiny humans.
Yes, they're actually in control. As much as you would hate to, you can get up in the morning and then they will decide how your day will go.
Alrighty, so if you could do it all over again, would you choose the same path for yourself? Are there any opportunities that you would have taken now that time has passed?
So it's an interesting question. I think I would, if I were to do it over again, I would be a doctor. There are some changes that I would have made. You remember how I talked about the 4 decades, and I talked about this 10, first decade I'm going to use in learning, and this 10 decade I will use in. What I would have done is that the last 2 decades that I left in the last 2 decades, I would have included them all around. That even while I was doing my training, I could have done a lot of the services that I wanted to do in terms of community service. I would have done a lot of the global health that I'm doing at the 3rd decade and the 4th decade. The reason I say that is that when I designed those 40 years, there's something I didn't count in, which was having children of my own and having 4 children. So when that comes in, it begins to change a lot of your schedule the way you thought it would be. So if I were to change it, I would have done a lot more integrating my 3rd year and my 4th decade of the way I planned it, which is to mentor people, be able to train people, be able to support them, and be able to do community service. Those that I left for the 3rd and the 4th decade, I would have integrated them right from the beginning. That's the change I would have made. Mm-hmm.
Perfect. Thank you so much. So how has COVID-19 impacted your work?
Oh, it's been something that nobody actually planned for. So it is something that suddenly changed the way we all live and the way we all conduct what we wanted to do. So normally what I do is that I would come to ELCO for 2 weeks, work in ELCO, and work for about a month, 2 months. Then I'll take 2 weeks off. I will travel to Nigeria. And in Nigeria, I go to work with pregnant women and children. One of the programs we have in Nigeria, we work with a large population. Right now, we have about 60,000 women of childbearing age with HIV. And one of our major focus is to make sure that none of these women delivers a child with HIV. Because we believe that once a woman delivers a child with HIV, our idea of a HIV-free generation is destroyed immediately, because that means the next generation already have HIV. So I used to be able to travel to do that. When COVID started, I actually was at the airport on my way to Nigeria to do this, and the airports were shut down. So I came down, and then we started to revise to a way to do it. So thanks to Zoom, I was able to now start having weekly meetings with my team in Nigeria when they go out for this program. And one of the things that amazed me was that we were able to conduct our meetings 3 hours every Monday. And we did that every Monday of 2020 without missing one. So I think, I think we didn't know it, but I think we were prepared for what happened with COVID by technology. Because imagine if this COVID came in a few years back without Zoom, what would you have done? So I think those technology prepared us without our knowing it, that when COVID came in, we were able to continue the work we do. So I was able to still give lectures to medical students and nursing students at the University of Nigeria. At the same time, be able to talk with the team that go out in the community programs that we have there. While at the same time, be able to do my work here as a clinician. So I think COVID came, but I think we were prepared for it without knowing about it, and thanks to technology.
I think there was like that lag in between for everyone, and we all had to kind of process it. And then once we figured out, oh, we have all these tools, it became more business as usual, or, as usual as we could make it.
I'm not even sure that we are going to go back to what it was before, because we find out that the way we have, I pretty much felt that I was more productive in during this period than you would think about. So think about cutting out all of the travel that I didn't need to do, and I can still do that work. Through that, I mean, you still need human interaction, so travel is still going to happen. But there are certain things now that you could do by Zoom that we didn't think before that we could do. Last week, you won't believe it, I saw my doctor through Zoom. I did a Zoom visit to my doctor for my annual visit. I didn't think anything different. I mean, I enjoyed it. So she may not see me for a long time. I may end up seeing her on the Zoom as my doctor. So I think it has really changed the way we were living, but it might change the way we get to live.
I agree. So our next question comes from the chat. And the question is, what advice would you give to a young college student?
One of the things I will give to someone that is graduating is that I will take a little bit back to my time in college. As you remember, I didn't have the luxury of maybe going to college for 4 years and then going to medical school. So I went from high school straight to medical school for 6 years. So when I look back, and you can see how it shaped my things. So I was all structured, 10 years of this, 10 years of this, 10 years of this. What I will give to a young student would be to say, remember that it's not the end that really matters, it's the journey. And that's why I said, if I were to make changes, that I would still have the 10 years as a plan, but I would have started all of them at the same time. And yes, I may value them differently. And that's what I would say is that if you are young and you wanted to do nursing, for example, one of the things about nursing is that in school is as tough as a medical school. You have to do all the clinical work you have to do. But once you graduate and you start working, you suddenly find out that what makes nursing a great profession, just like medicine, is the flexibility of things you could do. You could work 12-hour shift for 3 days and you're working full time. You could decide to work 3 days and take a week off and come back. So there are so many flexibility. So with that flexibility, you find out that you can actually build all the things you want to live. They say you can't have it all, but actually nursing or medicine gives you the opportunity to do that, because you can work through that period. You're also raising your children, because all of these things happen about the same time. But also you can decide that one day you're going to volunteer at a community service program a week. So there are so many different things. I have one of the nurses at the hospital who has been at the hospital for 30 years now at the labor and delivery. And she is going to volunteer to come to the clinic to work with first-time moms who are trying to breastfeed. So she's a lactation consultant at the hospital. And then, as you know, that's the only hospital in Elko. So almost all the patients coming are delivered at the hospital, unless they deliver outside Elko. So one of the things we're trying to do at the hospital, for example, is that 48 hours after babies are born and discharged for the hospital, we want to be able to reach out to them, make sure that they have been linked to a pediatrician in the community. And if they have not been able to link to a pediatrician in the community, we are willing to see them at the hospital clinic, where we see them irrespective of insurance. So one of the things also that she's doing now is to volunteer to come to the clinic and work with first-time moms who are breastfeeding to make sure that they achieve a good period of lactation as long as they want, sometimes up to 6 months. So what I will make sure is that you don't just do the 10-year like I've done. Yes, it's good to make that plan, but I want you to integrate those services into it. I think it'll be more fun for you.
Perfect. Thank you so much. So our next question also comes from the chat. What's the biggest challenge you faced in your line of your career, and how did you overcome that?
There are professional and private personal challenges, and I will speak to both of them. One of the personal one that I will start with, first of all, I think when you are younger and you're making these plans, you don't plan for, the children coming and suddenly that is not about just your plan. It's the plan of your spouse, it's the plan of your children. So, but that's part of life. So it's something that that challenge was striking that balance of being able to be there for your spouse, be there for your children, and be there for the career that you also like. So being able to achieve a balance of those things, I'm happier today than I thought I would be, because I think finally I've achieved that balance for me. Now I can work for the hospital. When I'm in the hospital, it's busy. But then for 2 weeks, I have a break. And during that break, I could do what I'm doing right now, right? I'm happy to do it. I enjoy doing it. It's really something that I truly enjoy doing. So I'm able to do that because I have achieved a kind of a balance for me. So that achieving that personal balance is one of the challenges you are going to have. And that will require not just you, initially just you, then you get married, and then there is somebody else to also think about their time. Then you have children, and there's more people to think about them, depending on how many of them you have, right? You have to go to basketball, go to volleyball, go to soccer, go to all of those. So that balance is something that was a challenge. Professionally, is that people will try to define what success means to you. You have to take control of that and define success for yourself. Nobody can define success for you and you'll be happy with it. You are the one who have to decide that. When you decide what success means to you and you pursue that success, you find out that you essentially be happier with that. Why some people may decide, like I decided at the first time of career to become an academician, become assistant professor, associate professor, full professor, and teach. I enjoy to do that. Maybe I made less money than I would have made if I have gone to clinical practice, but that was a choice I decided. And for me, becoming a professor was a success. But if you actually go to where people want to bring out money, I may not, I still drive the car that I drive as a fellow. It's 17 years. Tell you how bad it is. I gave it to my daughter. She refused. It's not because I can't buy another car, but it's something that car started with me, and I hold it like this is my car. And my daughter would say, "Daddy, give it up." You say this car is older than me. But again, I told her that I use it for an example to teach my daughter that this car that I drive, I can buy another car. But the world is not going to determine to me the car that I want to buy. This is the car that is sentimental to me. Is the car I started my career with. And if it's working, I'll probably be driving it as long as it will. But that's me defining what success means to me. It's not about buying a new car or doing something else. And that is something that I think you're going to face professionally, where you have to decide what success means to you. And don't let other people take control of that and determine success for you. The challenge with other people determining success for you is that they keep moving the goalpost. And then every time you think you've achieved it, they move the goalpost again. But if you determine what success is, you can celebrate when you reach that. People might not even know that you've reached your success rate, but you are the one who set that goal. So I think that those are the two challenges that personally you have to strike a balance that allow you to achieve goals and success that you predetermine for yourself. You can change those goals, but let it be you that is changing it and let other people change it for you. So those are my two. I know it's a long one, but I thought this is an important area to look at, the personal and the professional one.
No, that's perfect. Work-life balance and defining your own success is definitely one of those things that I also view as that's always going to be the most challenging thing for any young college students or anyone in general. Our next question is, do you see a difference in your position and what you have to either work with or what you have to work through when it comes to more urban areas or more rural areas?
Yes, there is a challenge that can be there, but also there's an excitement that can be there at the same time. So when I'm in ELCO, as you remember, I'm a pediatrician, but I'm also trained as a pediatric infectious disease doctor. But I'm not the specialty. I'm not a neonatologist. I'm not a cardiologist. I'm not a neurologist. So you find out if you are in a big city, you'll find out you can always call them to come and see a patient. But when you're in a rural area, you will face a challenge where you have to be able to work to provide the best care to this patient. And that is not always just transferring the patient outside of the hospital. So, for example, there are a lot of things we are doing in Elko, the hospital that is quite innovative, is that we have people that you could be there, have an EKG done at Elko and be read by someone that is at the primary children hospital. We are doing something new that the CEO of the hospital thinks is a very good idea. And if it happens, one of the reasons we transfer our patient to other hospital is to get a pediatric echo before they are discharged if we have a consign. And sometimes we transfer this patient to primary children and they do the echo and then they discharge them the next day. And you say, and they come back to echo. So now we're working to be able to have ability to do the echo in the cardiogram in Elko, but have a cardiologist in primary children with that. And if it's normal, then the child doesn't have to travel to Salt Lake. And if it's abnormal, then we can ship the child to Salt Lake. So being in those in the rural area, you may not have access to all these specialties, but it actually brings in the innovative part of medicine. It makes your day non-boring. So it's not the same thing you are doing every day. Yes, in the city, you may have all these assets, but you may notice, oh, call the neurologist, oh, call the cardiologist. So that's all you do. Whereas in the rural area, you may become a little part of that to some extent and be able to coordinate the care. So they have this balance. For me, I've been a doctor for 25 years now. So I have the experience. And I think when you are in a rural area with some experience, it does help. So sometimes I say, oh, if you are beginning your career new, maybe you need to go to the city, get out the exposure. But when you do come to a rural area, that experience helps you a lot. Because there are so many things I can manage now as a doctor that if I was fresh out of school, I may not be able to manage. The 25 years experience does actually help.
Thank you. So our next question is about your work with the HIV Medicine Association. So can you give us a little more information on what you did in that association and what you enjoyed the most while working with them?
The HIV program was one interesting one. It wasn't initially how I started. I wanted to start in my life. I was doing, as an infectious disease doctor, I was focused on doing research on fungal infections of the kidney. Something that was big. I had my research all laid out. But at the time, I was training in Rutgers, which was in Newark. And we had the largest number of HIV patients. We had the largest number of women of childbearing age with HIV. So we had a number of children who were being delivered with to mothers who had HIV. And also we had the highest number of children who were born with HIV. So there was a lot of challenge in that area. And one of the things they have, one of my mentors from that place is called Lesky. And he used to bring me to his office and show me a picture that he framed. It was a news article on New York Times where they had him on a picture and called him the alarmist doctor. They called him the alarmist doctor because in 1983, he described the first pediatric HIV patient. At the time, HIV was thought to be a gay disease, and he was showing that children can also have this disease. And the New York Times put his picture there and called him the alarmist doctor. And he said, this is how I started my career because I was trying to describe what I saw. And he was really a mentor to me because he gave me programs to run. And what I noticed was that over time, you get connected to the HIV Association with every other person doing something. That's how he succeeded. When he came up with the first case, he saw somebody in LA came up with another and said, I'm seeing the same thing. And somebody in Louisiana came up, I'm seeing the same thing. Suddenly, they were no longer alarmist doctor. They were able to prove that HIV can pass from women to their children. And we know that today that we have the resources to do it. But we did an excellent job in Newark in that even though we had the highest number of children being born to HIV impregnement, for 5 years, they were able to make sure that no child born in Newark had HIV. And through that association, when I come to meetings, I'm presenting all the work we're doing. And then they were talking about Las Vegas, where it was a smaller population of women, but they were having 3 to 6 people that were children that were infected with HIV. That's what brought me to Nevada the first time. I thought I can come in here and put in a new program in here. And I did. When I came in here, I designed a program which was a different from a clinic. I don't really like to run clinics. Some people do, but the difference between a clinic and program is that you come in, you sit in your office, people show, if they don't show, you stamp no show, and you move on. But a program, you call back. Why didn't you come to clinic? Was it transportation? Was it this? And then you connect them to people who can help with transportation to the hospital. So there's a little bit more to program than clinic. So when I came in there, I put in this program. I was the first maternal child HIV program, and I went on television, Channel 3, to talk about it, that we can stop these children from being infected. And one of the philanthropists in Las Vegas saw this message on TV and called my chairman at the University of Nevada, Reno, and said he wanted to speak with me. And he said, you believe that children born to HIV infected mother can be prevented from having HIV? I said, no, it's not a belief. We already have all it takes to make sure that a woman who is HIV infected can be treated during pregnancy, and they will have a child who is not HIV infected. He said, well, then why are you not doing it? I said, because we are running a clinic, not a program. He said, what do you need to run a program? I said it was $400,000 we had. We wanted a place to run all these things I'm talking about. Because I said, doctor, you're limited to just seeing the patient. How about those social services that are connected to that? Maybe the child didn't come, the mother is not taking this medication because they're also on drugs and you need some drug therapy. So she actually put in this money, and the state of Nevada, the health department, was really, really very gracious that they said, you know what, we will match this program for the next 3 years. And they did. And that's how we started our HIV program in Las Vegas. From 2007, after we started it, to 2012, for 5 years, we had no child born in Nevada with HIV. So he was a very successful. He was one at top of my career. But although one of the things that I noticed doing that was, I now realized once we no longer had the children presented, everybody said, oh, we have to cut the program because there's no longer children infected. Even though the number of women with HIV was increasing and we're doing a good job preventing that transmission, the program health is designed to pay for care, not prevention. So all that we're seeing is that, well, no child is infected again. Why are we still supporting this program? I said, but you're supporting this program to achieve this, that no child is infected. Because how did we come to the 400,000? That's how much it takes to treat a child, one child with HIV. So we said, if we can prevent one child with HIV, the program already paid for itself. And here we are preventing no child for 5 years. But anyway, they cut the program. It took me off. I was so upset that I decided that I wanted to meet the Secretary of Health in DC. So I started looking for how to do that. And one place I found was to do my fellowship with the Robert Wood Johnson Health Policy Fellowship. And that's something people should know about. Faculty member. I was a faculty member then. I was an associate professor. And then I took a year off to go to DC. What they do is that they bring in 6 people from around the country who have been in practice in different areas. They bring them to DC, and you're supposed to stay with the Congress or with the health department. Either you have to stay with a senator, which is really they would like, or a major health committee in the Congress, or you stay with the Secretary for Health, nothing less than that. So I spent some time in the Senate with our own senator then. But then I at the time was when healthcare reform was passed, so there was a lot of politics in the Congress, and a lot of the work was directed to the Secretary for Health. So I decided I went over to the Secretary for Health and spent a year with the Secretary for Health at the time was Kathleen Sebelius. And through that program, I remember her asking me, what is the program you're running? Why is it not running? And I told her this story. And actually that was the way we brought the first federal funding for maternal child HIV program called HIV Run White Part D to Las Vegas. So that program was funded, is still in place right now, and is being managed by the University of Nevada School, UNLV School of Medicine. But I and the team, we brought down that first funding from the federal government to Nevada to do that. So the HIV program for me gave me a way to actually contribute to the community. Today, I still see some of those patients that we were able to make sure that they had children that were not infected. And it is satisfying to me. And it's something that we're doing globally now. And that's why we have these 60,000 women that we have in Nigeria. And our goal is that these 60,000 pregnant women will have their babies, and none of those babies will be infected. And I'll be smiling the day we achieve that.
That's perfect. That sounds absolutely fantastic. That work is definitely one of those those types of works, and it's very important to make sure that we have something like that. You brought up a very big point. People will see that the goal finished, and then they don't realize, oh, wait, no, we can continue this, and it can continue on. And that's always very interesting. Our next question is follows your work with the CDC committees for immunization practices. Can you tell us a little bit more about what you did there, and like what was your favorite part with that?
So, so this was one of the things I wanted to learn because I believe that as a doctor, you start your career as a nurse, as any healthcare provider. What you notice is that the first time you start, you are dealing with one person at a time, one patient at a time. But after a time, you realize you can actually make change. So one of the things we did was I noticed was to advocate in 2006 for the state. So if you look and Google SB 216, that was the first law that mandated HIV screening for every pregnant woman in Nevada. So CDC made that recommendation in 2006. Nevada became the first state to implement that. And we went to Carson City to lobby for that, and they passed SB to pass that law that actually mandated all pregnant women to be tested instead of stratifying what we used to do. Oh, are you at risk? But the idea was that the major risk for having HIV is having sex, and every pregnant woman has sex to have babies. So why discriminate and say this one have other risk? Every pregnant woman to have a baby. So we said, why don't you screen every woman? And that way there's no stigma associated with it. And we pushed for that law, and just by a single passage of that law, that was why we were able to achieve that, because we screened all women. So we were able to identify the women and started the treatment. In 5 years, we didn't have any child infected. Why? Because we were able to screen that. So you could see how policy can affect even a bigger change than your individual interaction with one patient at a time. So that was something I wanted to see at the national level. So I went back to ACIP. ACIP is made up of 15 people selected across the country in different specialties, and they're voting members of the ACIP. And you see the immunization schedule that is released every year. This is our new flu recommendation. This is our recommendation for immunization for this year. That all comes from the 15 members of the ACIP that votes. So you served there for 5 years. So for me, I served from 2015 to 2019. You served for 4 years, sorry. And during that time, you sit with these 15 members, you look at information brought in by drug companies that have done clinical trials, you determine the approval of vaccines. Just right now, for the COVID vaccine, you see that once FDA approves it, it moves to the ACIP. It's ACIP that makes the recommendation to do that. So that was a lot of what I did for those 4 years with my colleagues at ACIP and the CDC, was to come out with those schedules. If you look at the recommendation of immunization for the country, you still see that I was the author for that particular recommendation for immunization, routine immunization for the country. It gave me an opportunity to see how policy can make a change in health outcome. In addition to the individual changes we make one-on-one, but how policy can make a broad change in that. And those kind of approval was there for me. One of the major things I learned from there is really, in medicine, we used to look at the drug companies at the dark side. So when a doctor moves from seeing patient to the industry, we say he has moved to the dark side. But then being there, I recognize that a lot of science is driven by pharmaceutical companies. Look at the COVID vaccine. I just received my second dose at the hospital in Elko, and you see that we're able to have hope. And look at that, be a time we can all be in the same room again without all of us masked and be able to talk again, and we can have this conference like this in real person, right? All of those happen because of science, and a lot of that science is driven by the pharmaceutical companies. So instead of seeing them as the dark side, I started to see them as collaborators in the same pursuit of this health outcome that we all want. So it was one thing that definitely changed my mind. And up to today, I do believe, of course, we want to look to make sure we were the ones that had to review what they have done to see that these things are safe, that they're efficacious, and that the community should take that. And one of the things I did was to be able to take those vaccines myself, to encourage people that I know that I believe the science that this vaccine is safe. I believe the science that is effective. I believe the science that these are not just dark side and conspiracy about it, that is something that will help us return to whatever normal we will face. So those 4 years I spent there gave me an understanding of policy at the national level and how it can drive science and how it can drive health outcome, just like it did at the local level when we passed the SB 216 for the HIV program. So this was very, very, it was time I spent, those times when I was 1 year with the Secretary for Health to see how the health reform was being implemented, or whether it was the 4 years I spent at CIP at CDC to see how immunization recommendations are made, or whether it's time I spent with the state to pass those laws with there. You see that policy does have an impact as a, so when you are a healthcare provider, you should be an advocate. And one of the ways you can advocate is to actually contribute to the policy development, because they will be there and last longer that you are in any position that you are in.
Well, it's incredible how much work you've done. I mean, in the United States and globally, all of that is just so amazing and so impressive. So our next question comes from the chat, and the question is, are there any upcoming technologies or advancements in the medical field that you expect to change your job?
Yes, there is a lot that is coming out. There is I can show you a little one that I'm actually working on right now that is interesting. I was showing it to at the hospital to some of my colleagues. I think I have it. I'll show you. That is something that is amazing, and I'll show you why I think it might change. I think I showed you some of this card. You see this card? I have it. It says my health card. Okay, one of the things, a lot of the things that we have had is that with this card now, if you scan this card, it's a QR code, it's an oldest code, but it's this one of the simplest one. But if you have the scanner that can read this information, if you scan this card, you will get all my medical history right out. And if I give you this kind of permission, that this card is actually also linked to my facial recognition, which, there is always that debate about personal infringement and personal thing, but it is there, you have this card. But if I were in an accident, for example, I travel globally, which is why I found this very interesting. If I were in an accident and I couldn't talk, I was unconscious, and they have that, and they can scan this card. And if they can scan this card, if they scan my face, you will bring out all the information that is here. You will bring out the drugs I'm taking. You bring out my blood group. You will tell you what my blood group, you tell you what my genotype is. You will tell you, so if I need a blood transfusion, it can reduce the time of that blood transfusion, knowing that that is there. It will tell you the drugs that I'm taking, and that will give you some information. So I think over time, this is some of the things we're going to have that is going to help. And guess what? This is the same card you use to swipe into your hotel room. And after you swipe it, what do? You trash it. That's 5 cents. But in this 5 cents, I can have all my information here. So for example, now this particular work was supported by the National Institute of Health for the development. And we're using it now on these 60,000 pregnant women where they can receive their care in any clinic. And then without losing it. So if they come in there and provide information, they can pull out the medication there, they can pick them their drugs. So there are technologies small like this that are going to make changes in the way we do things. And over time, one of the ones that I'm actually doing is access to health. You remember how we're thinking about even getting the ELCO done in Nevada. So now there are technologies that are coming in is that I can actually take my phone and all the apps that I need and do this echocardiogram on a child. And the cardiologist in Utah will be looking at what I'm seeing in real time and be able to read that echo. Think about that, what you would do to very resource limited settings, whether in this country or globally, where they may not even have an echocardiogram machine, but they have a cell phone. And they can take the app there and do that. So I really think that technology is going to drive a lot of healthcare. And if you are someone who is interested in technology and interested in health, I think there's going to be a lot of challenges that you can solve coming forward.
It's amazing that you can use your cell phone to do a highly advanced medical, my mom had to have EKGs. And she would have to go to another hospital, and it was always this big scary thing that she would dread. But it's amazing that we've advanced so far within 20 years that it can be done on a cell phone. That is incredible.
Yes, I was in Nigeria. I'll tell you this story that makes me very hopeful. I was in Nigeria. My family was here in Nevada, and I started feeling dizzy. And I called my wife. She said, why don't you get to a doctor? I'm gonna go to the cardiologist right here. So he went to the cardiologist. I went to the teaching hospital there, and then with the cardiologist, say, can you do an echocardiogram? I put it there, and he did an echo. And the cardiologist here in Nevada was reading my EKG in Nigeria and was telling me, oh no, doc, you don't have any heart attack. You should be just get up and go to your work. But he could tell me right and then that I wasn't having a heart attack. This is way, way, way back in Nigeria in a place that was nothing. So I really do think that technology is going to drive a lot of new medicine. And before we used to have people in technology there and the people in medicine there, but now being able to connect these people it's going to be what is going to drive people that have, and that's one of the things you can remember about nursing that you think about. Think about nursing and think about the opportunities you can do with it. You can decide to remain a bedside nurse, which is contributing, you're taking care of patients. That's very wonderful. You can decide to go to public health and not see a patient one-on-one and do public health. You can decide to go to pharmaceutical companies and develop the new vaccines, the new drugs, and all of those things that are there. You can decide to go to health policy and decide. You can do global health. Again, think about it and think about technology. If you are the one that is a technology wonk and you want to do it, think about working in this small startup that we're doing and try to come up with this kind of thing. It's just excitement that we're getting a group of people. I have no idea how to do what I just told you, but it was finding somebody who I said, I'm trying to, this card that they scan and throw away, that means he has information that opens the door. Can I put medical information in it? He said, yes. I said, can you do it for me? He said, yeah, what do you want? So we sat down together and we were able to crossbreed and do that. So I'm excited about the future.
So our next question veers into your role as an educator. So as an educator, what class is your favorite to teach and what is the most difficult to teach? Are there any moments that you would consider the most impactful you've had on students?
So it's funny. So my dad was a professor of psychology. He died a while ago when I finished medical school. But so he would teach. And he used to tell me that even though he has taught for years and as a professor, that there is one group of teachers that he respects a lot. I say, which one? He said, your mom. My mom is so my mom teaches in the first grade before she become a primary school head teacher. And he said, teaching somebody who has no idea of anything is one of the difficult things. He said, by the time people come up and have an idea, it's easy to teach them. So if you actually look, my easiest class to teach is when I'm teaching PhD students. Why? Because somebody has already prepared them. They already know all the acronyms. They already know if I say echocardiogram, they know what it is. Imagine if I have to try to describe to them what an echocardiogram means. So one of the most difficult times I find in teaching is when I'm teaching a basic class. So when I have undergraduate and I'm trying to teach public health principles, for example, that is one of the hardest class I teach. Whereas if I get me a bunch of PhD students and I'm teaching them research design, and I'm at home because it's so easy because they already understand a lot of the basic principle and I can go all the fancy part of it. But I've taught along all of these levels. The one that I do find the most interesting is actually teaching people the basics. So if I was going to teach research and I'm teaching people the different types of research design, it becomes actually the first time they're learning the research principle, whether they're in nursing school, they're in medical school, or they're just undergraduate public health students. That basic part of it is something because I think that gives them a great foundation in terms of understanding the teaching that will occur. And if I prepare them very well, somebody else who is going to teach them later is going to enjoy it because I've laid a very good foundation. So having thought of all these classes, I found the most challenging is to teach the basic classes. And then the most exciting is when you are doing all the wonderful things somebody has prepared them for. But teaching is something that I enjoy because I still do believe that when you teach, it's like those principles you say, see one, do one, teach one. And even though you're teaching somebody else, it actually improves your own skill and improve your skill. So every time I teach, I find out that I learn something.
Perfect, thank you. Author of over 70 scholarly articles and awards, more than 20 awards and honors. That's a very impressive feat for really anybody. How do you personally make the time on your schedule for not only completing the position you're in, teaching, and then also being a scholar on that?
So I think that's a principle in my own particular way that I find. There are people who have done it more differently. But if you can imagine, for all the things that I do to have time to do this, what I believe that helped me and still helps me up to today is that I believe in team science. If you look, anybody that wants to work on a project by themselves, do all the thinking, nobody has the monopoly of ideas. So I have always believed in terms of having a team. So if you think about it, when you have a team working on a project and you want to write a manuscript and you have 4 people in the team, and the manuscript is essentially 4 different parts. There's a background, there's a method section, there's a result, and there's a discussion. How about if you split that and every person writes the draft of one and you combine them and you're able to look at? So what I used to tell my team is that we are going to have 1 publication every month. So every year we have 12 publications, and that's what we focus on. Some years we come to 10, some years we do 15, but on average we want to do 1 publication a month. And that is possible because of team science. Not only will you enjoy the interaction with your colleague, but also you learn quickly that you don't have a monopoly of ideas, and that these 4 people that are coming together to do this, it's going to be better than what you're going to be able to do by yourself. So team science is what I believe in. In my team, I have people from public health, I have nursing there, I have doctors there, I have dentists there. I have those teams because whatever you are going to design, having people that see things from different perspectives. You had say, what can you be as a doctor? What is a doctor without his nurse? But the truth about it is that when you come in there, I remember when I was in medical school, if you come to the ward, you cannot go to see your patient until you go to the nursing station and say, I'm Dr. This, and I'm going to see the patient in room 12. If not, they will call you back because they say, we are the custodian of the patient right here. And that's the thing, because if you decide you weren't going to go to the nurses first, guess what? You're going to come back to them, because you go back there and then you come back and say, oh, this patient, can I see if he's been having fever? And all of them will keep quiet. They go figure it out. You want to go there and see the patient yourself, all right. But then you're going to come back, you want to see the vital sign, you want to see what has been going on with the patient. Who guess who is going to give it to you? The nurse has been there 24 hours. You just came in to do rounds. And so, if you work in the healthcare system, you understand that the healthcare system works as a team. And that's how I was trained. That's how I practice. And that's how I still practice. Whether it's writing a paper, designing a research, or any other policy thing, is always a team science. And that's what I enjoy.
So we have one last question from the chat, and this is one that I am very interested in myself. So what advice do you give to parents or new parents as a pediatrician, and especially now?
So there is I remember one of the greatest advice that I was given as a parent when my children was trying to go to school. And one of the teachers said, we go to school, we think that the most important thing is for the children to learn A, B, C, and D, or learn 1, 2, 3. He said, that's not important thing. I said, well, that's the important thing I'm paying for. He said, no, that's not the important thing. The most important thing about going to school is to make that child love school. That once you make that child love to go to school, the child will do the rest of the things that you have. That if you can't make that child love school, they're not going to learn all those things. It becomes a difficult job for them. But if you make them see, oh, it's time to go to school, and they say, yay, you have done your job as a teacher. So for me, as a doctor, I think I follow that same principle for somebody who have done things, especially when I see first-time moms. They worry, am I doing the right thing? Am I doing the right thing? Is this the right way to do it? Is this the right way to do it? I always tell them 2 things. I always say, when we were born, we weren't given a manual on how to raise children. And I tell the children that when they start growing up. I say, your parents weren't given any manual. But there is only one guiding principle to them, is that they want to do the thing that is best for their child, what they believe is the best for their child. And I give them an example. I say, when I was growing up, now we know, they say, don't smack your kids, don't do it, it's all bad. When I was growing up, there was nothing else my parents could do to me to heal apart from smack me. It wasn't the best thing now, but at that time it was. Why is it not the best thing now? Because there's other forms of punishment. If my daughter does it, and I'll take their cell phone from them, and then they will make them do something. Well, at the time I was growing up, I didn't have a cell phone. There was nothing they could take from me. So there was no other kind of punishment that I could actually listen to. So it was funny enough. But now, with all this form of things you can use to, punishment is supposed to help correct. With all of these, you're not going to go to a basketball. Well, you're not going to use your cell phone. There are other ways you can, make the child do what you want to change, you want to do instead of smacking. By the time I was growing up, I think my parents didn't really have any option than smack me. So I said, things change. But the most important thing is that they have the same intent in mind. They wanted the best for me. And as a parent, you don't have a manual on how to raise a child. You want to do the best thing that you can do, but you have a partner as a parent. You have me, your pediatrician. And if there are questions on whether am I doing it right? That because they come in and they're worried about asking you a question that looks stupid. So in my clinic, I tell them there is no stupid question. If you have a manual on how to raise a child, please share with me because I still struggle with mine. If I take my children to the doctor, I'm an ID doctor. My wife is a doctor. We take our kids to the doctor and he said, Dr. Izzy, why are you bringing this child? I said, well, Dr. Izzy is at home. This is daddy. I am not, this is daddy. I am daddy. So please tell me what to do. And they laugh at me, but it's okay. And that's what I tell my parents, that you as a parent, you want to do the right thing by your child, but also there's no manual how to do the right thing. But in a pediatrician, you have me as a partner in terms of health decisions. And if there is health decisions you're considering, you want to make, I am here for you and I can give you the best advice that will help you making that decision. So that's one of the things that I actually tell them, because once they feel that they can ask you anything, guess what? They will ask you the right question they need. And then you can provide them the right answer. But if they feel like you are standoffish and they can't ask you a question and they feel stupid, you have closed the door to make any impact on them.
Well, that was so wonderful. And we are at 12:30. So I just wanted to thank you so much for taking the time to share your stories and your experiences with us. And we really appreciate you so much for doing this for us today.
Thank you for having me. And I'm really available. I enjoy doing this because it was the same thing that people did for me. I have held podcasts with students to think about careers and the opportunities that exist in careers. I have been exposed to a lot of them. So whether it's in nursing, in any healthcare area. So if there's any of your students that ever saying, I don't know what the heck I'm going to do when I grow up, I'm available to be able to talk with them. Is something that I enjoy a lot. And I'm hoping that one day, through the foundation that we work with, that we'll be able to have an opportunity for your students to travel with us to Nigeria, and maybe one day bring some nurses from Nigeria to spend some time at your institution. And I enjoy this. And please, if there's any way I can be of time to spend with the student, I'm happy to do it. And thank you for having me.
Yes, thank you again so much. If all of you enjoyed today's events, please follow us on our social media channels, as we will probably have events similar to this. And Dr. Easy probably will be with us again at some point in the next couple of years or so. So again, if everybody could follow us or give a round of applause to Dr. Easy for the amazing work he's done. Thank you so much, everybody. And we hope you all to see you all soon.
Thank you.